So, good morning, good afternoon, good evening. Welcome to the AEPC YouTube channel and to the AEPC intervention series. My name is Regina Bokenkamp, and I'm the chairperson of the working group intervention of the AEPC. In the time of the COVID-19 pandemic, when unfortunately all teaching courses had to be cancelled, our juniors came up with the idea of an online teaching session. And this idea had to do something with the master and apprentice manner, how interventional cardiology is taught or needs to be taught. We are all a kind of craftsmen. So today, I'm happy to present to you a lecture on PPVI. The master will be Professor Andreas Eicken from the German Heart Center in Munich, and the apprentice will be Michał Gałeczka from Zabrze in Poland. He will discuss the question that came up during the lecture at the end. And so I wish everyone an informative lesson and want to thank all contributors. And last but not least, Linda Boschers from the AEPC office, who helped us a lot with organizing these lectures and also with the technical finalization. So the floor is yours, Andreas.
Dear colleagues, ladies and gentlemen, I'm really happy to speak about percutaneous pulmonary valve implantation. My name is Andreas Eicken. I work in the German Heart Center in Munich, and I'm very happy to give this lecture for the AEPC. This is a historical slide which was given to me from Daniel Tanase. So the history of percutaneous pulmonary valves dates back into the year of 1992, when a Danish physician, Andersen, put in a porcine pulmonary valve in an animal. A couple of years later, Philipp Bonhoeffer started with his valve in lambs, and Sochman used the valve you see here in dogs. The first implant in human, and that actually was the first percutaneous pulmonary valve implantation on the world, was done by Philipp Bonhoeffer in the year 1999. 2 years later, Crépier introduced valves in sheep in aortic position, and the first in human was published in the year 2002. By that time, Philipp had treated 8 patients with a Melody valve. In 2004, Crépier published the results of 7 patients in whom he put a TAVI procedure, aortic procedure. Here you see Philipp with his first patient. It was a 12-year-old boy with pulmonary atresia and ventricular septal defect after a Blalock shunt and corrective surgery at the age of 4 years with an 18mm Carpentier-Edwards conduits. And now he had stenosis and regurgitation of the conduit. And successfully, Philipp implanted a Melody valve into that conduit. So the PPVI was introduced to extend the right ventricular outflow tract's conduit life. So also the approval was reached not to put in a new valve, but to extend the lifetime of a surgical conduit, to relieve conduit stenosis without inducing regurgitation, to restore and maintain pulmonary valve competence. The timeline, again, the first procedure was done in 1999 and published in 2000. In 2006, Melody reached CE mark approval in Canada, and also in Munich, we treated our first patient together with John Hess and Lee Benz. The FDA approval for the Melody valve was in 2010, and CE mark for Sapien XT for Europe was 2011, and 2016 Sapien XT got FDA approval for pulmonic position. Now here you see the two commercially available valves. I will not go, because you all know them, I will not go too much into detail, but the Melody valve is a bovine jugular venous valve, which is sewn into a GTM platinum stent, and you can implant it on an 18, 20 or 22 millimeter balloon. Through it is introduced in a closed system, which has a 22 French delivery outside. The Sapien S3, which we use at the moment, is a laser cut balloon extendable stainless steel frame. The stent is very strong, and it's available in 23, 26, and 29 millimeter external diameter. The sheath to deliver it seems smaller, but the outside diameter does not really differ. The main difference between the two things is that one is a closed delivery, and this is an open delivery system. So PPVI indication were published in Cardiology in the Young in 2017. I will not really go through this and read it to you. I think everyone can read the indication in the paper. Recently, Helmut Baumgartner for the European Society of Cardiology for the adult congenital group has also defined the indication for percutaneous pulmonary valve implantation, and this was published in the European Heart Journal, and you can see here the recommendations also. I will not read them. So PPVI in patients with RVOT dysfunction is indicated. There may be a right ventricle to pulmonary artery conduit, it may be valved or non-valved. There may be a failing bioprosthesis. There may also be a native right ventricular outflow tract if the anatomy allows a percutaneous pulmonary valve. And of course, the patient has to be large enough for these huge or big delivery sheaths. Something that is very important for us to know if there is a bioprosthesis in place is if it's distensible, like a homograft or a Contegra, or if it's non-distensible, like a Hancock. It has a metal ring. You cannot increase the diameter of a Hancock valve. And if you have a Hancock valve of 18 millimeters, the internal diameter is only 16. So if you put in a valve, for example, a Melody, you make it even smaller. You go to 15 millimeters. So you have to think about which conduit you have. The first patient Philip treated had a Carpentier-Edwards valve, and this is an example of that. And this is also a non-distensible prosthesis, but I will come to that Peter Evert had the idea to crack this valve and to increase the valve diameter for gaining a bigger diameter. So this is this you see here on a bench with an Atlas balloon, a Carpentier-Edwards prosthesis. The internal band is broken, and Daniel Tanase published this already 8 years ago, that you can increase the valve diameter by up to 3 or 4 millimeters, which is important in the long term. Now, which patients are amenable for percutaneous pulmonary valve implantation? I took this from the paper from Philip Lourdes, from the original 155 patients treated in London. And more than half of the patients had a tetralogy of Fallot, 9% were after a Rastelli operation, 11% had a common arterial truncus, 8% were after Ross operation, and there was a miscellaneous group of 11%. So nearly everyone has these patients. So I would like to go through a patient step by step. First, Melody valve implantation. This is a 14-year-old boy, 56 kilos, 174 centimeters, with common arterial truncus, who was corrected in the first year of life with a 9 millimeter homograft between the right ventricle and pulmonary artery and VSD was closed. 1 year later, a bigger homograft was implanted, and now at the age of 14, he had systemic right ventricular pressure and a peak invasive gradient of 43 millimeters of mercury between the right ventricle and the pulmonary artery. The diameter of the here at the site of the bulbus of the homograft was around 15 to 16 millimeters. So after this angiogram, we usually select the balloon for the balloon test. In this case, we chose a 16 millimeter double balloon because this would be the balloon also for us to implant a covered stent at first. So here you see our balloon test with a 16 millimeter bib. We always start with an aortogram, and if the coronaries are far enough distant, we leave it by that. If the coronaries are close, we would take a Kevlar high pressure balloon and open it up to the diameter we would finally reach. But then, of course, you have the risk for conduit rupture. And we may also need, in this situation, then selective coronary angiograms, and we may need different views, like, for example, the barrel view. In this case, you see that we placed a Meyer wire distally into the pulmonary artery, and I like this J that it comes back. The stiff end ends here, and the aortogram is done with a 5 French pigtail. So we start with a balloon test with the outer balloon of the double balloon, distal guide wire positioning with a pigtail or with a 6 French coronary guide. This can be very helpful. At best, that the soft tip does a 180. You have to be careful not to perforate at the wire transition. So I prefer the Meyer wire because Lunderquist has a very short, soft tip and may work its way backwards. In smaller children, we also take the Amplatz ultra stiff. We start with the aortogram, then the decision if selective angiograms or additional projections are necessary. In selected cases, a coronary wire may also help to define the coronary proximity to the balloon. So we implanted a covered 39 millimeter stent on a 16 times 14 millimeter double balloon. In this case, a 12 French sheath was big enough for that. And then it was dilated with an Atlas 18. And if you look closely, there was a small contained rupture here, which made us stop at this point. In adults, we consider to implant an 18 French long sheath in the groin for easy exchange and also for predilation of the delivery system. Pre-stenting is obligatory in Melody PPVI to avoid stent fractures because Nordmeyer has shown that 21% of patients have stent fractures if you only use the Melody CP stent and don't enhance the stability of the stent. In homografts, we use long covered stents through a braided sheath, usually the Cook flexor. There's also a braided 14 French, which is called Deville, but most of our patients are treated with a 14 French non-braided Cook long sheath. Contained conduit rupture may be sealed with additional CP stents. You always have to look for that. And the combination between covered and bare stents dilated to the maximal anatomically possible diameter with ultra-high pressure balloons is effective. So you should spend a lot of time to create a nice wide landing zone. Which final diameter should be achieved? Well, if you take the internal diameter of the Melody valve, you have to keep in mind that the outside is 2 millimeters more than the inside. But large internal diameter, low residual RVPA gradient gives you a good long-term result. So you should really work on that and not hustle. So I come back to our 12-year-old. 2 months after the initial procedure, we see that the contained rupture is still present, even a little better to be seen. So we placed a second covered CP stent, and we dilated everything to 22 millimeters. Then we implanted the Melody valve on a 22 delivery, and we were very happy with the result. Residual gradient of 6 millimeters of mercury and pressure of 42 in the right ventricle and nearly 140 in the aorta. So an example of a patient with a native outflow tract and step-by-step Sapien valve. This is a 12-year-old with double outlet right ventricle fallow type who was corrected at 6 months of age. He now has declining RV function. The right ventricle is enlarged, although this 150, 160 millimeters per meter square is not reached, but he has this declining exercise tolerance. And also what you can see here, there is some tricuspid regurgitation. So what we do is a balloon test. In this case, we took a VAX 30x60 balloon, and we did an aortogram. Coronary arteries were far away. And then we also injected a contrast through the long sheath to see that the contrast is not bypassing the balloon. Just keep in mind, this is 30 millimeters. So we are at the end of Sapien 29, which is outside diameter is 29. But we decided PPVI is possible in this case. So what we did was we selected a 43 millimeter Andra XXL stent on a 30 millimeter double balloon. You see here under rapid pacing in the left ventricle, we implanted the bare metal stent. And you see there is a little tiny waist, and we like to see this because then the next step, putting in the big dry seal sheath 26 for the Sapien delivery is good. So in native RVOT with severe pulmonary regurgitation, PPVI with a Sapien valve is possible without pre-stenting, but we like to do it to have a good landing zone. We always do a coronary testing and also a testing into the long sheath if the contrast passes the balloon. For pre-stenting, we use bare metal stents of large diameter on large double balloons, delivered through rapid pacing for a safe landing zone, and then we deliver the Sapien valve through the 26 dry seal sheath to protect the tricuspid valve that it doesn't get entangled there. This is what you see here now. You see that the dry seal has been retracted. The Sapien, and in this case, it's a 29S3, is under rapid pacing, is delivered into the pre-stented area, and at the end, the position of the valve is good. There is some leaking, but this is catheter position because in echo on the next day, there was no pulmonary regurgitation in this patient. There was also a good hemodynamic result with a gradient of less than 5 millimeters of mercury. So our experience in Munich with percutaneous valve implantation, it's not all pulmonary, it's also tricuspid, it's 400 patients. So actually pulmonary valve, we did 360, tricuspid, we did 37, one in a TCPC, one in a tricuspid bioprosthesis in a Zenning, and one in a mitral bioprosthesis in an adult. Median age was nearly 20 years, from 4 years to 79. Median weight was 60, 70 to 176, more males than females. Most patients had a tetralogy or pulmonary atresia. There was a common arterial trunk and Rastelli patients, Ross patients, and the miscellaneous group. Most of our patients had a homograft. 66 had a native outflow tract, and 118 had heterografts. So Melody was 326, Sapien was 67 patients. Now, this is known, the danger of the procedure, coronary compression. Here, a patient after Ross procedure, and we did the balloon test, in this case with an old-fashioned Atlas balloon, and you see simply that the left coronary is gone after the balloon test. And of course, in this patient, this is from the lateral. There's the left coronary artery, which is occluded by the balloon, which is not even fully dilated. So this patient cannot be treated with percutaneous pulmonary valve implantation. The other risk, if you take a high pressure balloon, is that the conduit may rupture. And this happened in this calcified porcelain patient, where after the valve implantation, we had a conduit rupture and we lost the patient to severe bleeding. We couldn't save him. Stanimir Georgiev published our results in the JACC Cardiovascular Interventions in 2019, saying that a low residual pressure gradient yields excellent long-term outcome after melody valve implantation. So 88% of our patients after 10 years were still living with a valve if the gradient at the end of the intervention was less than 15 millimeters of mercury. The other publication from our group was again from Stanimir, was published in 2020, when we compared the outcome of 452 patients treated either by melody valve implantation, 241, or by surgical valve implantation, and the follow-up maximum was 12 years. There was no difference between overall survival, surgery-free interval, and there was also no difference between survival with the original valve. Survival free of endocarditis is depicted. There was no significant difference between the two, although the annualized infective endocarditis incidence was 1.6% after melody valve and 0.5% after pulmonary valve replacement surgically. So 14 of our endocarditis patients were treated by operation and 10 were treated by medical therapy. Now, comparing our results with other groups, this is a paper from Tom Jones, Circulation from 2022, looking at the American initial long-term results. They have not such a good long-term result, but they were not allowed to use pre-stenting in the initial years. So there's no wonder that they had a higher intervention rate than we had that. Now, I would like to spend this slide on this very emotional endocarditis topic. I think this topic is not solved at the moment, but I think we should discuss it scientifically and not emotionally. And if we look at all the different publications, I think we should keep in mind that the only parameter that we can compare, and this was given to me by Harald Bertram, is the incidence per patient year. For example, if you look at our collective, the incidence is 1.6% per patient year, and this is exactly what was published by Shah Nawaz for the SAPIEN valve in the year 2020. In a very large paper also published in the year 21, the incidence was 2.2% from melody, and that was a lot of patients, 2,476 patients. In multivariate analysis, it was found that younger age, previous history of endocarditis, higher residual gradient were risk factors for endocarditis, but transcatheter pulmonary valve type was not. That was multivariate comparing the SAPIEN and melody in this paper. So still, I would like this discussion. I'm not completely sure what will be in 10 years, what we say to it. I just would like everyone to know that I think the only comparable value is the incidence of endocarditis per patient. So now I come to other studies that compare the outcome. Here, a study published by Shah Nawaz in 2020 on SAPIEN implantation, 774 patients, many native outflow tracts, Most patients received the S3 valve. This is also the valve that we put in at the moment. And most patients put in 29 or 26 millimeter Sapien valves. So this is also the valves that we implant. Technical success was really high. Adverse events were 10%. Urgent surgery, second valve, tricuspid valve complications. Valve function was excellent in most patients. And the follow-up is relatively short, just 12 months. And this is just a short term. And this is the largest study that is published so far in 2022 by Dov McElhinney, and 2,476 patients. We also gave our patients to this registry more than 8,000 patient years, 2,000 melodies, 438 sapiens. Survival was 91% after 8 years. Risk for death was prosthetic valve elsewhere, or PACER or ICD. Cumulative risk for reintervention was 25% at 8 years, for surgery 14%. And the risk factor was younger patients, prior infective endocarditis, or PPVI into a stented bioprosthesis, or post-implant gradient. There it comes again, was also a very important factor. And here you see the Kaplan-Meier from Dov's study. Survival, the worst group were the oldest, which is clear. And reintervention was highest for the youngest group was because they outgrow their conduit, which is also understandable. So finally, there's 2 approved valves. You see them here. I like them both, but I would be very happy to have more, and to have it more also in Europe, like the Harmony, like the Venus P, like the Altera as a more or less landing zone for a sapien. Pulstar valve we have used in 7 patients. Excellent results. I really like this valve, and I'm looking forward that we have it. So in conclusion, PPVI is one of the most significant advances in the treatment of patients with congenital heart disease in the past 2 decades. The intervention is safe and effective. Coronary compression and conduit ruptures need to be avoided. Both approved percutaneous valve, Melody and Sapien, have excellent immediate and Melody also long-term results. Melody is limited to RVOT diameters below 25 millimeters. Sapien may be overextended a bit to 31 millimeters. So far, longer follow-up data, patient years, are available for Melody. Compared to surgical pulmonary valve replacement, similar long-term results can be expected after PPVI with less morbidity for the patients. The approval of large set expanding valves enables the treatment of patients with larger outflow tracts, and we are really looking forward to this. Thank you very much.
Hello, everyone. I would like first to thank Andreas for the thoughtful and very comprehensive talk on PPVI. I honestly really enjoyed it, and I think all the young interventionalists will do as well. I would like to thank also Regina Bokenkamp as the chair of our working group for being and our working group as a whole for supporting this initiative, which I think is very, very educational for all the young interventionalists all over Europe. Let me also thank Andreas not only for the talk of today, but also for the organization endorsed by the AEPC of the course, basic training course on catheter intervention that is due in Munich next 5 to 7th of May, which in which 20 young interventionalists from all over Europe will participate. And I think this is a great event, a great occasion for all of us. And finally, I want to remind all people who are interested that the Interventional Working Group of the AEPC has organized a thrilling lunch session during the next conference in Geneva, end of May, which title is Junior Interventionalists Meet Seniors, and where a bunch of young interventionalists will meet seniors like Gianfranco Butera, Daniel De Wolf, Mirella Molnay-Schott, Alan Fraise, and Aphrodite Zifa, which will discuss with them their career perspective, their doubts, and trying to answer their, their doubts. I mean, and I don't want to waste any more time, so I will ask Michał Gałeczka from Poland to go ahead and ask some very hard questions to Andreas.
Okay, once again, thank you for such interesting talk. The first question will be about indications for PPVI. How do you think, what's the real cutoff for the right ventricle end diastolic volume index to intervene? Is it really 160 or maybe less?
Michał, thank you very much for the question. I think the volume index and diastolic one is just one piece from the whole picture. So I think there is publications on that if you go over this value that the ventricle may not go to normal, but it may even be that the end systolic volume is even more important, or the whole clinical picture of the patient is very important. I also think that if there is a declining exercise tolerance, this is also very important. So I think just to say that if you have this 160 or 150 end diastolic volume, it is not the only thing. It's an important factor, but certainly not the only thing.
Okay, thank you. And the next question is, what is the minimal and safe weight according to you for PPVI?
The minimal and safe weight. Well, the smallest patient we treated was percutaneously was 17 kilos. But certainly if you put in this huge 22 French and the Sapien, is only 16, but if you really look at it, how it is in the patient, it's also 20 French. So if you put in this huge sheath into small patients, it is advisable to have the patient as large as possible. So the lower limit may be below 20 kilos, but if you can get the patient over 30 kilos, the intervention is more easy.
Okay, and if you put the valve in such small kit, what's your approach, jugular or venous then?
Well, we mostly take the femoral, but jugular is very nice, especially in very difficult, if it's very hard for you to reach the position from the femoral, it may be much smoother to go from the head. And but in practice, we only from our 400 cases, we've done only maybe 5 or 10 from the neck.
Okay, thank you. Some question about the landing zone. If you have a homograft which is heavily calcified, and especially that there are circumferential calcifications distal to the RVOT, how do you calibrate such RVOT and how to check the coronary arteries then?
Very good question. The first thing is you should think about what diameter do you want to reach. So in general, a big diameter and a big valve will last longer because then the gradient between the right ventricle and the pulmonary artery at the end of the intervention is low. And if you reach a low gradient, you will have a longer lasting result than if you end up with a gradient, let's say above 25 millimeters of mercury. So you should really work on your landing zone to have it as large as possible. On the other hand, if you have a heavily calcified conduit, it will rupture, it will break. So you have you have the risk for a non-contained conduit rupture, and you also have the risk to go on the coronaries. It is very difficult to know if you have a very calcified conduit, if you will impinge on the coronary arteries. So it is very difficult to make a general suspicion. But what we would do is we would really start with a very good 3D imaging, that is CT or MRI scan. So this helps us to have a basic idea. Next, we would always go with a balloon test. We would always, even in a calcified homograft, we would go for a balloon test, but we would not primarily break the conduit, but we would probably take the double balloon with which we want to end up and just inflate it to 1 or 2 atmospheres in the calcified conduit to have an idea if coronaries are close or not. So we would combine this with an aortogram to have a basic idea what is going on. After that, and after we made the decision how big we want to go, we would use, in a calcified homograft, we would use a covered stent that is covering the whole calcified region. What is very dangerous is if you have a calcified homograft that does a 90-degree angle. You know, sometimes these cannot be treated because they may rupture from the ventricular side to the pulmonic side. And in my lecture, I had one of those examples that would break really badly.
Thank you very much.
Does this answer your question? And then after we put in a covered stent, we would go by 2 millimeters by 2 millimeters until we reach, with a high pressure Atlas balloon, until we finally reach the best and the largest diameter possible.
Okay, thank you very much. Few questions about the bioprosthetic valve cracking, which is so popular now. What is your preferable size of the ultra high pressure balloon to fracture the bioprosthetic valve ring? How many millimeters do you add to the inner diameter of this valve?
For example, if you have a Carpentier-Edwards valve 21, the inner diameter will be 19. And for this, I would take it Atlas 22. Then the question is also, would you take it bare or would you put in a stent? I would probably take a bare metal stent into this valve and then inflate a 22 millimeter Atlas balloon. And we just did one last week. And well, we did it under rapid pacing because sometimes it's difficult to stabilize the high pressure balloon in this valve and go up to 20, 25, sometimes 30 atmospheres, or even until the Atlas breaks.
Okay, and has bioprosthetic valve cracking become usual approach at your center now?
Well, usual approach from 400 cases, we've done maybe 10 crackings. They were not always successful. I mean, we didn't have complications, but we didn't always manage to really get a larger internal diameter. It was not always possible. There's a nice paper from Aarhus. First author is Johansson, and they have it's published in Euro Intervention, and they found out which conduits you can crack and which you can't. For example, trifecta is a conduit that they couldn't crack. Of course, a Hancock conduit with a metal ring you can also not crack. But it's a nice paper to read which conduits you can crack and how you can make it bigger.
Okay. A few questions about balloon interrogation. If the coronary arteries are really far away from the landing zone in the CT, do you always check them in angio?
Yes, we would always do that. I think it's good also for you to get used to that, you know, to really, because the depiction of coronary arteries and to assess whether it's safe or not is very good for you to learn also. So I would always say I would never just trust 3D imaging and just put in the valve, at least not with a balloon with a balloon extendable valve. Maybe you could do that with a self-expanding valve, like which is now available, the Pulsar valve. We've done 7, and probably you can be more generous in not doing balloon tests. Although in those 7, we always did a balloon test. And we always start with an aortogram and don't intubate the coronaries to be sure that not the origin is covered by the balloon.
Okay. What is your approach if the RVOT calibration causes the aortic root compression with or without aortic regurgitation then?
Well, if I would see aortic regurgitation, I would do nothing. I know there's a paper from Abul Hossein, I think it's in CCI 216 or 217, when they first mentioned this. And there's another paper that came out 2021, so just recently, in pediatric cardiology, where they also found this. Personally, we have not stopped one single intervention because of this. But if I would see that it would impinge on the aorta, causing aortic regurgitation, I would not put in a big valve, pulmonic.
Some short question. Do you have any preferred branch of the pulmonary artery, right or left, if you put a PPVI, if you do the PPVI?
Where the wire wants to go.
Yeah, where to put the guide wire, yes.
Yeah, where the wire wants to go. If you place your wire, we usually do this with a king pigtail, and you see where the pigtail wants to go. Then we put the pigtail in the pulmonary artery, and we usually, we very much like in adults, we like the Meyer wire, which is soft in the beginning. So it comes back with a 360, and then we push it forward. So if it's the left, usually it's a nice straight curve, and this could be nice. But in some patients, you need the right pulmonary artery. And a good trick I was taught by Jacques Qureshi, if you have difficulties to find a distal position, you can use a coronary guide 6 French and safely place the wire distally, because it may be sometimes difficult to place a stiff wire distal in the pulmonary artery. And Jacques taught me that to use a coronary guide, which is very helpful.
Do you always use the Gore dry seal sheath to implant the Edwards valve? And what with smaller?
Not always, but at present, if you implant a Sapien valve, it's unprotected. So it can be stuck in the tricuspid valve. For example, Milano has published, it was Gianfranco who has found that 10% of his patients had a problem with a tricuspid valve after Sapien implantation. And we also had a Sapien valve. We had to actually take it out. We didn't push it through, but it was stuck in the tricuspid valve. And we had to take it out of the body and start going through the right ventricle again, because it was entangled in the tricuspid valve. So if you put in a Sapien and you feel a stop, you should not try to force it through the tricuspid, because you may break the tricuspid valve. I heard that Edwards is now in the process to make a closed delivery, but until we have that, I prefer to take the dry seal. But you are right, in smaller patients, dry seal is very, very big, and you would like to not take it.
Mm-hmm. And short question also, melody valve and balloon in balloon, which balloon should be deflated first and why?
Well, I never thought about that. I would always start with this inner balloon and then the outer balloon. And we've done it many times, but we didn't think about it. Actually, I ask you back, why do you ask this question?
Okay, because there are many hypotheses what should be first, and that's why I ask.
Okay, I can only say I never thought about it. Thank you for the question. But we always start with the inner balloon and then the outer balloon. The idea to take the inner balloon first is that you more or less don't get a diabolo. If you start with the outer balloon, it may happen that you know, just the ends open. And in the worst case, you have a diabolo. And if the balloon breaks, you have a disaster.
Okay. Do you somehow prepare the patients before PPVI to prevent them from infective endocarditis?
Very important question. I speak to them for a long time. I tell them about their teeth. I tell them about the infection. And of course, especially percutaneous valves have an increased risk for endocarditis. It is higher than biological valves. I'm implanted surgically. So I tell them that they should really look for that, and parents and also the patients go to the dentist, look for every skin lesion, be very, and I try to scare them a bit on that. But still, there is an indication for there is an incidence of 1.6 to 1.8% per patient year of infective endocarditis.
Mm-hmm. And some questions about peri-procedural protocol. How many days of antibiotics after PPVI, and do you heparinize the patient after this?
Well, we heparinize in the catheter laboratory, and actually we give 3 shots. We give 1 before, and on the first day, 2 additional ones. And this is a difference from our other practice. I don't know what Regina does, but usually we only give 1 shot in the at the moment. Yeah, so if we implant an implanter, if we implant a stent, we just give 1 shot before, and after that nothing. But in PPVI we give 2 additional shots, but only on the first day.
We do it exactly the same. 1 shot for antibiotics before all other implantations, and 3 in PPVI. So.
Okay.
But it's all gut feeling. There's no evidence for this. It's just, I think, Regina, would you agree?
Yeah, I agree. And the 3 shots are, I think, from the first protocol we wrote in 2007 on it.
Exactly. Exactly.
And what about anti-aggregation treatment after PPVI? Do you administer this?
Also, open question. Nobody knows. We give 6 months of ASS. Nobody knows. There's people like Mark Hebelik, they say you don't have to give anything. And there's people like Younes Boudjanlim who says you have to give it lifelong. And nobody knows. We give 6 months.
Okay. Yeah, me too. 6 months as well.
Thank you very much for all the questions.
Thank you for asking.
Interesting.
Thank you.